Let me call the first presenter, Icro Meattini from Florence, Italy, presenting on exclusive endocrine therapy or radiation therapy in women aged 70 plus with normal-like early breast cancer, a pre-planned interim analysis of the randomized EUROPA phase 3 trial. Icro.
Thank you, Michael, for the nice introduction. On behalf of the EUROPA Trial Steering Committee, I would like to thank for the selection of our contribution. These are my disclosure information. So a bit of background, basically based on the breast cancer in older adult women. We know that this is a high prevalence of breast cancer in estrogen receptor positive stage 1 breast cancer, especially including patients aged more than 70 years old. So basically, to reduce the treatment burden and try to balance the treatment efficacy and side effect, including health-related quality of life, is crucial. However, currently, the current standard of care is still breast-conserving surgery for the vast majority of these patients, followed by postoperative radiation therapy, and the majority of these patients receive adjuvant endocrine therapy. From the past, this is the study rationale and objective challenges from the previous studies. Unfortunately, all the older adult radiation omission only, unfortunately, trials demonstrated that basically if you omit radiation therapy following the primary hypothesis of the phase 3 trials, you obtain a significantly higher risk of local relapse. At the same time, we have to take into account the side effects and adherence persistence challenges issues related to the endocrine therapy in these potentially fragile patients. So there's the need for a direct comparison between endocrine therapy and radiation therapy. We acknowledge a lack of data comparing a single modality radiotherapy and single modality endocrine therapy after breast conserving surgery for patients aged more than 70 years old. So this is the objective of the EUROPA trial. Evaluate health-related quality of life, at the same time local control has two co-primary endpoints and having a direct comparison between the two treatment arms. This is the trial design. Basically, this is a phase 3 trial. Overall will be 926 patients, breast-conserving surgery, with or without sentinel node biopsy of patients affected by PT1 and 0 or CN0 invasive breast carcinoma, estrogen receptor, progesterone receptor positive more than 10%, Ki67 less than 20%, HER2-negative patients aged more or equal to 70 years old, randomized 1-to-1 to receive single modality postoperative radiotherapy or single modality adjuvant endocrine therapy with two co-primary endpoints: health-related quality of life as measured by global health status at 2 years and ipsilateral breast tumor recurrence at 5 years. Following these stratification factors, age class 70-79 as compared to 80 plus, and geriatric age tool score less than 14 as compared to more than 40. Treatments. This is real pragmatic trials. So radiotherapy arm can be hyperfractionated whole breast or partial breast irradiation with favor the 5 fraction and partial breast irradiation following the international guidelines, and endocrine therapies as well, aromatase inhibitors or tamoxifen, 5 to 10 years as per treatment physician choice. So it's a pragmatic study. Statistical assumption. This is, of course, an interim analysis and was pre-specified, pre-planned when the first 152 patients enrolled reached the 2-year global health status health-related quality of life follow-up control. We had also to check stopping rules in terms of local control and distant metastasis. Of course, at the very end, the overall number of patients randomized in this trial will be 926 patients. Of course, the health-related quality of life is a complex analysis based on the EOTC, C30, and BR45 model. Patient characteristics. That's basically the vast majority of patients at an age class of 70-79, so really not more than 80, 74% of patients around at 70-79, and G8 score class, they are fit patients, more than 60% of patients has a score more than 14 points. Concerning other important characteristics, the majority of patients had tumor more than 5 millimeters, so it's PT1B, PT1C, 90% of patients around, and not G1, the 65% of patients has a G2 tumor, so it's really a wide population. Primary endpoint result, CLQ, C30, global TEL status. That's it. The blue line is radiotherapy, the red line is endocrine therapy. The higher, the better. This is the empirical least square mean change from baseline to 24 months. Radiotherapy arm, this is decreased change from baseline, between baseline and 24 months, around 1 point. If you look at the endocrine therapy arm, the change from baseline to 24 months is around 10 points. If you look at the adjustment following the age and G8 class, again, there's no significant difference between baseline and 24 months in the radiotherapy arm. There is a significant difference in terms of decrease of health-related quality of life in the endocrine therapy arm. And already now this is a preliminary analysis, the mean difference between the two treatment arms, this is a primary endpoint of the study, is statistically significant. This is exploratory analysis, of course, since it's an interim analysis. The C30 functional scales, radiotherapy arm basically showed a better performance as compared to endocrine therapy for most of the functional domains, so physical, emotional, cognitive, and social functioning. Here, the higher, the better. If you look at the C30 symptom scales, here the higher is the worse. Of course, radiotherapy arm again showed better outcomes as compared to endocrine therapy arm for most of symptoms domains. Consider that this is an exploratory analysis, of course. B45 is really important. Functional scale breast module is the higher, the better. No statistically significant difference between radiotherapy and endocrine therapy arm for most of the functional domains. And concerning symptom scales, we already are able to see some important signals. Radiotherapy arm, of course, showed better outcomes as compared to endocrine therapy arm for most of symptoms domains. And here, endocrine therapy shows statistically significant worse in terms of systemic therapy and skin mucosis symptom scores as compared in this comparison group. Survival outcome. This is an interim analysis, but at 24 months we have no ipsilateral breast tumor recurrence as expected and local regional relapse in both arms. No distal metastasis, no breast cancer related death. Very important, adverse events. Treatment-related, treatment-emergent adverse events showed 67% of occurrence in the radiotherapy arm as compared to 85% in the endocrine therapy arm. There is a difference of around 20% between arms in favor of the radiotherapy arm. That means, if you look at this table with all the grade 1, 2, and grade 3 or plus, and here highlighted the occurrence of more than 20% adverse events, that profile of endocrine therapy is much, much more than the whole in terms of adverse events. And means that 22.5% at 24 months already of patients in the endocrine therapy arm needed a switch in the endocrine therapy kind, and 12.4% already needed an endocrine therapy permanent discontinuation, and this is only 24 months. The current status of the study. This is a multi-center Italian and Slovenian study, 21 recruiting centers. At today, 858 patients, 92% of patients have been enrolled. We are going to close the study in 2 months. Of course, we have to acknowledge some limitations. This is an interim analysis based on a subset of planned cohorts. Limited long-term efficacy and safety data should be acknowledged. So the follow-up duration is a median follow-up of 24 months. So the long-term outcomes is pending. And there is, of course, a generalizability acknowledgement for this luminary-like breast cancer patient age more than 70 years old. However, the conclusions of the study, in this interim analysis, we already evidence that radiotherapy may offer a better health-related quality of life as measured by global health status preservation as compared to endocrine therapy at 24 months. We evidence the lower incidence in terms of treatment-related, treatment-emergent adverse events in the favor of the radiotherapy arm, and no warning signal regarding stopping rules in terms of disease control. Of course, future directions, ongoing patient recruitment and follow-up. Final analysis, of course, will include the co-primary endpoint of ipsilateral breast tumor recurrence, so hopefully we'll be here in some years. And the take-home message really, really important. Radiotherapy or endocrine therapy may be a suitable, viable, single modality treatment option. We are accumulating data, so we should always emphasize the need for a true multidisciplinary and a true patient-centered personalized care. I would like to thank patients first and their caregivers, importantly in this patient population, all the investigators, the participating centers, Fondazione Radiotherapia Oncologica that supported for non-profit a pure academic trial, all my colleagues in Florence, the EUROPA investigators, the study coordinators Lorenzo Livio and Philip Pormans, all the steering committee. If you are eagerly waiting for details, I'm proud to announce that the EUROPA trial will be published today after the general session in the Lancet Oncology. Thank you very much for the kind attention.
Thank you, Icro. Questions from the floor? Microphone 2.
Peter Dubsky, a surgeon from Lucerne. Congratulations, first of all. Maybe we missed it, but we were looking for how many of these patients had ultra hypofractionation, so very short courses.
Yes, in this interim analysis and in general, currently in the world study, 85% receive partial breast irradiation, the majority with ultra hypofractionation, so the 5 fractions. And concerning endocrine therapy, that for the sake of time, of course, there's no chance the majority receive aromatase inhibitors. It's 80% of aromatase inhibitors, 80% of partial breast irradiation. Thank you, Peter, for the question.
Microphone 6.
Great.
Vogel, New York, very nice paper. Kevin Hughes, in his study that was first published about 20 years ago of radiation versus not for a similar patient population, reported a lot of ipsilateral pain that lasted years in the radiated patients. Did your quality of life and instruments pick that up?
Yeah, of course, we are going to record all this data, and this is something that we should take into account. As I said, I think this is not a challenge between radiotherapy and endocrine therapy. We just try to highlight the profile of these two treatments in order that the treatment physician can really choose the best for the profile of patient that I have run. And this is something that should be taken into account, of course, I think.
So do you have any data on it to tell us
We have
today?
data also on that, yeah. We will collect it, yeah. Thank you for the question.
Last question, microphone 3, Professor Robertson.
Thank you very much. Really good to see your study, and I think I'd like to emphasise it's great to see an academic-led study, so congratulations on that. You obviously said you need longer follow-up, and there's no one thing that predicts risk in breast cancer, but the group that we're probably really interested in is the grade 3 patients, 1A, 1B, 1C, grade 3. I can't remember what percentage of those patients you have in your study, and do you have enough power to look at that group who are at the highest risk?
For sure.
Thank you for the question. In the trial, tumor grade 3 was, of course, an inclusion criteria for tumor size less than 1 centimeters, otherwise any grade for all. But currently, and you will see in the publication of data, we have no G3 patients randomized. So probably the generalizability of this study will be for G1, 2 patients when really we are going to omit one or the other for this selected population. Of course, thanks for the question.
Okay, one final quick question, microphone 6.
Barb Schwartzberg, California. Obviously, your radiation patients are 100% compliant. How many of your endocrine therapy patients have discontinued the trial due to side effects?
Yeah, concerning adherence, you said.
I mean, there's 100% compliance with radiation.
Yeah.
How many ET patients have dropped out due to side effects?
22.4% at the current analysis, so this is expected to increase for the final analysis. We know the adherence of treatment, thanks for the question, it's really crucial for these patients. Thank you.
Thank you.
Okay, thank you.
Thank you very much.